The production of this show is made possible by the support of viewers like you. Please visit conversationsthatmatter.tv and become a subscriber. Thank you for joining me.
My pleasure, Stu.
Where are we when it comes to AIDS globally now? Because it's almost as though we stopped paying attention here in the Western world.
Well, the reality is that the pandemic has always been a relatively large issue in the south of the world and a relatively smaller issue in the north of the world. At the same time, we have come a long way in terms of testing, treatment, and addressing the concerns of the people most affected, so that the painful and visual tragedy that was the pandemic in North America, say, in the 80s and 90s, has basically been dealt with. And so the success of our highly active antiretroviral therapy, the cocktail that we discovered, meaning us, here in Vancouver, in collaboration with a number of other people, back in 1995, which was announced in Vancouver at the conference, international conference in 1996, made it so that death rates precipitously drop. The likelihood of people progressing to AIDS diminished dramatically. And today we know, thanks to our work again, that treatment also not only just normalizes the quality and the quantity of life that somebody infected with HIV is going to enjoy, but also renders them virtually non-infectious. So treatment has become the center of the global strategy for the control of HIV and AIDS. The global community leadership of the G8, G20, G9, whatever you want to call it, repeatedly has promised that they will deliver universal access to antiretroviral therapy to the world because they understood the value of this at a time in which it was only a compassionate approach. And when we turned the equation up, we crank it up all the way exponentially by demonstrating that not only this was compassionate, but actually it was a game ender. It could actually bend the curves, morbidity, mortality, transmission, new infections, everything that relates to HIV and AIDS could be dramatically altered. Then all of a sudden, our global leadership lost interest. Why? Because their voters lost interest, because there was no longer fear. You see, infections in the south don't hurt in the north. We're oblivious to it. Even the communities most affected in our own environment have moved on. If you were an activist in the 80s, you were fighting for your life. Far beyond the fact that you could be concerned about Africa or Haiti or whatever, you were fighting for your life. And you had friends and peers who were going wasted and had Kaposi sarcoma, and they were going blind. It was devastating. So this was fear. You fear for your life and the suffering that was in front of you.
Well, virtually everybody feared that they were a potential recipient of HIV.
So you, as an infected person, you would have been devastated by it, and your community felt vulnerable as a result of it. And so we were all in it. I always tell people, we were doing experimental work with, and I don't mind being totally candid, with drugs that at the time the Americans had lost interest on. The only reason why a young Latino in Canada could get a hold of these drugs to do a clinical trial, international clinical trial, was because pretty much nobody else wanted to do it. And so we were able to get the so-called INCAS trial. We were collaborating with Italy, Netherlands, Canada, Australia, and the States. In fact, that was in the 90s. Jupp Lange, my friend who died in the MH17, tragically murdered in that irrational accident, was one of our early collaborators in that study. And that study matured in December 1995. And when I went to the virologist that was doing the sophisticated virology for us, he turns to me and he says, there's something wrong here because I can't grow the virus. And the question was, is it wrong, or could it be that the treatment is working better than we anticipated? We figured it out. It was the treatment that was actually working.
This is here in Vancouver.
This is here in Vancouver. Within 2 months, a group in the United States announced similar results from another triple therapy cocktail. Within 6 months, we had written new guidelines. We presented it at the Vancouver conference in July 1996. We created such a wave of optimism that the norms that we put out in Vancouver were adopted by the north of the world in 1996, and then in 2000 by the south of the world. Now, what people don't realize is that those were phase 2 studies. You know, people don't need to understand what a phase 2 study, but a phase 2 study is an exploratory study that under no circumstances you would be allowed to make a clinical decision based on it, because it's purely just to see what happens.
It's almost at the theoretical level.
Right, and so typically for you to do to craft a new guideline, you would be expected to do a large phase 3 trial with clinical endpoints to see what really happens in terms of disease evolution, whatever. But why could that happen? Because there was panic. And so
people were dying.
People were dying. This is like Ebola today. Yeah. People will break all the rules, within reason, to accelerate the development of a new therapy or a new vaccine for Ebola, because people are scared. Even though the likelihood that Ebola is going to come here is remote, we just don't want even to have that discussion. We'll cut every corner with, hopefully with the appropriate rationale to get there. And the 90s were like that. What I regret, if you want, is that we, having solved the problem and having sort of bring a solution to the acute issue that was AIDS in the 80s and 90s, we actually handicap our own ability to generate the public outcry that would be necessary to tell Mr. Harper, you have to do something about AIDS, domestically and internationally.
Where are we at domestically then? Because I know globally we're shy of about 40 million people that have AIDS. Where are we at domestically?
Well, domestically, it's a very haphazard map that we're looking at. It's very sort of a meal piece kind of situation. Imagine this, in the province of British Columbia, and thanks, and I don't mind saying it because they really deserve the credit, thanks to the provincial government and the very strong and unwavering support that our program has had, even when we were called deranged and crazy, and so all along we've been able to have the necessary support to have a focused program that built the evidence and implemented the evidence to control the epidemic. And as a result of that, progression to AIDS in the province of Colombia is down by 95%.
Down by 95?
95%. Death from AIDS is down by 95%. We have virtually eliminated mother-to-child transmission, to the point that today a woman infected with HIV, say person comes to my office first day today, age 20, Dr. Montaner, I just tested positive for HIV. I would have said to that person a decade ago or two, well, sorry, your survival is compromised, your reproductive life is compromised, all kinds of handicaps here and there and everywhere. Mm-hmm. Today I will say, look,
your lifespan is
absolutely
dramatically compromised.
You were looking at a 10-year lifespan in the 80s, maybe 20 in the, say, 90s. Today we're looking at 55 years of healthy life added to that person.
Or more.
So
we can't tell.
But we have the certainty that our treatments today, if taken appropriately on a long-term basis, will take that person to beyond retirement age.
Normal lifespan.
And we have decreased new infections by 66% in British Columbia overall, predominantly among injection drug users, because of the very aggressive harm reduction practices that the government of British Columbia has been willing to embrace. Insight, needle exchange, opioid substitution, all of that. Contrast that to Saskatchewan. Our epidemic is going like this. The Saskatchewan epidemic is going like that. And 70% of the new cases in Saskatchewan are among First Nations.
Yeah.
And the federal government still says they're not interested about talking about AIDS. Well, I mean, we can't be like that. Manitoba, the epidemic is going up like this. 40% of the new cases in First Nations. No other jurisdiction in Canada has shown the declines that British Columbia has shown. Why? Because we don't have a federal strategy to fight AIDS. We're one of the few developed countries that since 2006, not surprisingly, when the current conservative government took the lead of the country, we have not renewed our strategy. And the epidemic has continued to evolve. British Columbia has shown the world how to control the epidemic. Globally, the United Nations has come and taken our model and made it the cornerstone of the global fight, and Canada wasn't even at the party. We were at the United Nations General Assembly. I was there with the United Nations program, of which I'm a senior advisor, to unveil the crowning of the Made in BC strategy, the so-called 90-90-90, as the cornerstone for the global control of HIV and AIDS, and our federal government wasn't even represented. Our strategy currently calls for at least 90% of people be diagnosed, of those that are infected with HIV, be diagnosed globally by the year 2020, and at least 90% of those to be offered sustained and high-quality antiretroviral therapy, the cocktail, the famous HAART or triple therapy cocktail, and then 90% of those to be virologically suppressed, meaning that the treatment is working perfectly so that you have no detectable virus in the blood of that person. If we achieve the 90-90-90 by 2020, by the year 2030, we would have decreased the burden of disease, morbidity, mortality, and transmission by 90% compared to the 2010 year levels.
That's because there's basically a 1-to-1 ratio, or a little bit more than a 1-to-1 ratio for somebody who's being treated and the likelihood of them being able to retransmit. Is that correct?
Both.
Yeah.
There is a 1-to-1 ratio, if you want, from a person treated to progress to AIDS and premature death. So you solve the problem of the person that is infected with the treatment. The test and treat approach basically solves your problem if you're infected with HIV, but secondarily, it prevents the infections that you could generate. It's difficult to say that there is a 1-to-1 likelihood of infection because, you know, over a lifetime, you may not transmit ever. If you're not sexually active, you're not using needles, if you practice safer sex. So, but while you may not transmit 1, I may transmit 10. So the average could be in the order of about 1. In general, for example, in Saskatchewan, we have a situation where the average is more than 1, and that's why the number of new infections continue to increase. In BC, the number of new infections is less than 1-to-1 because what we've done is by identifying people and bringing the treatment to them in a supportive fashion, we are basically subtracting them from the pool of infected potential HIV donors in the community.
So in British Columbia, are we following the HAART protocol where we are responding the moment you are identified
it's not what we're
as
doing,
HIV?
we have Pioneer here in British Columbia. So BC, going back a decade, was the first jurisdiction in the world that said, you know what, we're going to make the treatment free. The beauty of this was we were able to show that by investing a little bit more on bringing the treatment to the people, you actually, within a 3 to 5, 10 years period of time at the maximum, you actually start saving. Because as we have experienced in British Columbia, we just repurposed, you can say we closed the AIDS ward. We didn't close the ward. What we did is we made a statement, we used to have an AIDS ward, there is no more AIDS pandemic as it used to be. There are sporadic cases of AIDS here and there, but remember, we used to diagnose 2 cases of AIDS per day minimum in British Columbia back in the mid-90s. Today, we are lucky we see 1 a month.
So let me ask you, what does it cost to provide this kind of treatment to an individual patient versus what does it cost to care for them?
Right. That's
if they get AIDS.
So the equation is very simple. Because in British Columbia, it costs approximately $1,000 per month for the medication alone. Say $15,000 per patient per year if you consider an average, rough average of all the people that are on treatment. Some people are on simple treatment, some people are on more complex treatment, whatever. So, but what you have to recognize is that the cost of AIDS now is in the somewhere $500,000 to $750,000 if you
a patient.
right, if you let it get to that. So by identifying people, only by going out and spending money on encouraging people to be tested, by making them aware that they're HIV infected, already the likelihood that those people are going to transmit drops significantly.
So there would be a first cost saving if they never transmit again.
Right, and then if I manage to engage people on treatment early, then what happens? I prevent them from becoming ill, which saves me the hospital and the visits and the antibiotics for the infections, blah blah blah. But in addition,
which are considerably higher than anything.
Exactly, and the hospitalization, and then if the additional saving comes from the fact that the pool of people that are infected are no longer infectious, or virtually are no longer infectious because they are on effective treatment.
But here's the thing, we live in a first world country where we can make all those kinds of calculations and say the infected population is this size. And in British Columbia we're doing it, but as you pointed out, we're not in Manitoba and Saskatchewan.
Not yet, we're working on it.
You go to Africa and you start to take a look at the numbers, South Africa in particular, it's enormous. How does the government of South Africa deliver $15,000 worth of medication a year to each person infected?
Well, enter Bill Clinton.
Enter Bill Clinton.
President Clinton has been uniquely transformational in the field of HIV. And he has said it many times, I wish I would have done this when I was the president. To be honest with you, he had too many other things to worry about. But him.
But you hadn't completed your work at that point,
Right. So him having made this a priority has been transformational. He has actually played a critical role, among others, but he's to be singled out for it in changing the way we saw treatment for the south of the world. Today, the treatment that I described costing $1,000 a month or $1,100, $1,200 a month in British Columbia is available in the south of the world somewhere around 50 cents a day to maximum maybe 75 cents a day. So what I'm saying is,
a day.
Yeah. So what I'm saying is that you
can
get
$15 a month.
Yeah. So what I'm saying is that there is a lot of room for improvement. In fact, this model is now being discussed, not 100% applied, but it's being discussed for the newer treatments for hepatitis C that are going to be revolutionary. So it's totally doable. Malawi of all places is doing it.
So the components are, just to be sure,
HIV testing,
yeah,
free availability of treatment, and support. Remember, we are asking people who are infected with HIV to come forward. We need to get rid of the stigma, discrimination, because the more people perceive that being HIV positive will create problems for them to work, for them to go to school, university, or whatever, the less likely that they're going to go forward. So we need to work on that area. We need to support them, because if you're a single mother in a rural Malawi town and you're HIV positive, and all of a sudden we say, well, no, you have to travel to the clinic that is a day away, and you have to do that once a month. That woman is going to say, this is impossible. So we need to support these people. And support doesn't mean that we have to bring the money, but we need to bring the services so that this is doable. You cannot be virtually unemployable because you have HIV. We need to make it so that you can become a meaningful member of society and be HIV.
Well, I want to congratulate you and thank you for the pioneering work that you've done, and also wish you all the best as we move forward, because as we know, this battle is not won. We've maybe made it through the front lines, but that's about it.
Thank you, sir.
Thank you very much.
Thank you very much.
Yeah.
My pleasure.